So good morning and welcome. Good morning, good afternoon. My name is Pakti Hansodi, and I'm going to be your host today as we discuss in our fifth session, COVID-19 in pregnancy. So many of my India colleagues who on the RISE project who are hosting this session know that to the day, this time last year, I was 34 weeks pregnant, I think. And I had been COVID positive earlier in my pregnancy, and I was working in the emergency department and started feeling unwell and ended up being seen by our expert here. So there's a lot to cover here, not only the prenatal, the perinatal, and the intranatal and the postnatal period. And we have two experts from MGMIS Sevagram and Dr. Tori Halscott from Johns Hopkins University who are going to join us. So we'll start off with a couple of introductions. And for those of you who are new to our sessions, welcome. For those of you who are old, apologies for the repetition. So the agenda here today, we're going to start off with some introductions. Doctors Jane and Verma from Sevagram are going to present a case to help us really understand some of the complexities of managing COVID positive pregnant patients. We're going to have a discussion to address some of the many questions that individuals have, and please use the chat function so we can address those questions in real time. And then we're going to summarize with an evidence-based review. The goal is to end bang on time at 9:30 a.m. EST. So to get us started, I'm going to invite our host. And this week we have been hosted, as I said, by Sevagram Hospital and Dr. Archana Patel, Director of Health Services, Pune. And the government of Maharashtra has kindly agreed to say a couple of words to start this session. Dr. Patel, are you able to unmute?
Can I get the username, please, so that I can make them unmute?
I honestly don't know it. I'm sorry.
But I am afraid that
Dr. Patel is unable to join us. If so, it's okay. We'll just continue with our colleagues and I'll continue with introductions. And if all participants could unmute while we continue through introductions, that would be great. So I also want to thank the host facility. So Sevagram has been very key to our success here on the RISE project. Dr. Kalantari gave a talk earlier on mucormycosis. If there's any other host institutions, please mute yourself unless you're speaking. If there's any other host institutions that would like to partner with RISE, then please feel free to contact us. And who should you contact? So RISE is a USAID funded project led by JPIGO. JPIGO is a Johns Hopkins University affiliate. Our strategic advisor is Dr. Bulbul Sood, who's probably known to many of you. Our country director is Dr. Sumesh Kumar, and the chief of party for the project itself, who's overseeing all of this work in India in partnership with us at Johns Hopkins University, is Dr. Vineet Srivastava. A lot of all the work in India that has been focused on supporting Indians during the COVID-19 pandemic, building health facility resilience across over 3,000 facilities and across 20 states would not have been possible without the vision, the direction, and the strategy by USAID. And Dr. Sangeeta Patel, Amit Shah, Cynthia Gear, and Vijay Paul have been instrumental in not only helping us with some of these activities that you're seeing today, like the webinar series and the case management series, but coming up with strategies to support laboratory, scale up of technical assistance, innovative strategies for forecasting and supply chain, and then improving the oxygen ecosystem. On the Johns Hopkins side, we are supported by two individuals that I would like to mention, Drs. Valerie Asula and Dr. Pavna Sheth. They, in the background, have been helping our expert with their presentation, but will also be synthesizing all the information that's covered in the talk today to present to you a comprehensive review of the topic, up-to-date references, and additional workshops or courses that you can attend. So who are we speaking to today? I just want to thank all of you who have registered ahead of time. There's 488 people who registered who will be able to receive a recording of the course and the resources that I mentioned. In particular, we've had a lot of interest from the states of Andhra Pradesh, Punjab, Maharashtra, Karnataka, and Uttar Pradesh. The majority of our registrants are physicians, and I'm really excited to see that so many female leaders and colleagues are here on the talk today. So today we want to cover, as I said, that whole spectrum, right, from the prenatal all the way to the postnatal period. And so we want to learn a little bit about COVID-19 in pregnancy and the incidence of COVID-19. What are the strategies for managing COVID-19 mothers during the pathway of care, testing protocols, guidance around how to deliver babies from COVID-19 pregnant mothers, and vaccination in COVID-19 and pregnancy. And I'm going to start off by orienting us to this topic, Dr. Sushi Jain and Dr. Poonam Verma. And so I'll stop sharing my screen and so you can take over. Is that okay?
Yeah, thank you. Thank you very much, Bhakti. Actually, both of us are extremely grateful that you gave us the opportunity. And since Dr. Archana Patel could not join, so a few words from her side as well. Maharashtra has been in India one of the very progressive state, and when COVID came, we were the worst ones actually. Mumbai and a part of Pune and Nagpur, they were really, really bad. All of us have struggled from the government of Maharashtra to government of India to the individual institutions. So as you know, we can put in things together because this is one disease where probably none of us know what is the best treatment. We are still struggling to find out. So with that note, I would request Dr. Shuchi Jain, who's the professor in Department of Obs and Gynae, and I, Dr. Poonam Verma Shivkumar. I am heading the Department of Obs and Gynae. Both of us are going to share our views and would like to hear your views from that side so as we can make the things better. Over to you, Dr. Shuchi, please.
A very good morning to my friends in US and good evening to our friends in India. So last 18 months have been very tiresome and trying for all of us. We have learned, unlearned and relearned because COVID was a novel virus and all of us didn't know much about it. So today we are here to discuss about it. So I'm presenting one of the real life cases we came across during the 200 odd deliveries of COVID patients which we delivered in our hospital. Ours is a rural medical college and it's a tertiary medical college, and it was a COVID hospital receiving patients from nearby districts. So this is a 24-year-old female named ABC, primigravida with 37 weeks, 3 days, who was residing in a nearby district and presented with chief complaint of fever with cold, cough and loss of taste since 2 days. She had complaint of breathlessness since 1 day. RT-PCR was done at a private hospital which was positive. However, she was refused admission in 2 private hospitals and referred to our hospital for further management. Patient was triaged and directly shifted to the maternity unit of our COVID hospital. History of contact with a symptomatic COVID RT-PCR positive relative was present. So the question now is, how will you do a rapid initial assessment of this woman and how will you grade her severity? Which investigations are mandatory and which are optional? So the participants can contribute.
Dr. Jain, would you like the participants to respond in the chat?
Or do you want me to finish the case first?
Yeah, I think it's hard for them to respond. So I would suggest that the participants put the answers in the chat and you continue with your case.
Okay, fine. So, I mean, these are the questions which come to our mind when we come across such a patient. So on general examination, she was febrile with a temperature of 38.6, pulse was 98, blood pressure was 118 by 78, respiratory rate was 26 per minute, SpO2 was 92%, air entry was decreased in left lower lobe of the lung, and crepitations were present. Per abdomen, the uterine height was correspond to 36 weeks of gestation and fetal heart sounds were present. Investigations were sent. CBC was HB 9 gram, WBC was 18,000, platelet was 46,000, HSCRP was 18, D-dimer was 9.6, serum ferritin 150, and ABTT was 1.36. So again, the questions which may come up in your mind are that once you've come across such a patient, what are the issues faced by COVID positive women during labor, and how really is it different to care a newborn of a COVID positive mother? So she, in relation to her findings and her investigations, she was diagnosed with moderate COVID-19 disease and delivered after 14 hours in our COVID labor room. She delivered without a birthing companion. Baby was kept with the mother as her relatives were COVID positive. She was advised regarding the importance of face mask and hand hygiene while breastfeeding the baby. COVID RT-PCR of the baby was sent on day 2, which was negative, and rooming in was allowed. Now, on further deliberation of this case, what as a healthcare provider, I would like to think about is what medications are used in management of COVID positive pregnant women. So the treatment was that this patient was put on NRBM and she maintained a saturation of 95% with 10 liters of oxygen. It was gradually weaned and the patient was then put on nasal cannula and then maintained oxygen at room air since stage 3. Dexamethasone 6 milligram OD was given for 3 days, which was then shifted to methylprednisolone 10 milligram BD and then to OD. Injection enoxaparin 40 milligram subcutaneous was given for 3 days. Supportive treatment in the form of antitussive, antipyretics, and steam inhalation. Obstetric management, platelet 2 units were transfused, and she was discharged in 14-day post-admission. Once she was off O2 and was doing her 6-minute walk test, which was normal. So this was the case, and now we'll discuss the challenges in management of COVID positive pregnant women. Or if somebody wants something about the case management, some queries, some difference of opinion, then probably we can discuss it.
So the biggest challenge which we faced was not giving antenatal care to the patients. And you can see in this case that this woman was referred to number of places where she was not given antenatal care. And finally, she was referred to us. The disease which could have been caught in mild severity probably became moderate while she came to us. So that's the first challenge. And I would like to have the opinion of my audience to talk about it so that we can finally put in together how important respectful maternity care is, even when it is the COVID era.
So is anybody that wants to unmute and give as a viewpoint as to how they practice in their setting?
Yeah, we feel that if it is interactive, probably it would be really better than, both of us just talking about it. So it would be really great if all of you can please come up with the questions or answers, or if you have something in your mind, that would be really great.
Yes,
one
it's just
question from my side.
Hi,
Myself,
Tulsi.
Dr.
Can you introduce
from
yourself?
SBS Narennagar. Ma'am, I'm asking about one question. When we give enoxaparin to the patient, either she is term or before terms, sometimes they land in labor without any sign and symptoms of labors. This has happened in our hospital also. So there might be chances of bleeding, more bleeding.
The answer to your question is that, you see, we have to weigh two things. One, if the woman is in her moderate disease, severe disease, or critical disease, it's very important to save the mother. And because COVID is ongoing and the problems with the COVID are constantly going on in in that particular women. So our first aim is to ensure that the women does not go into DIC. So that is something very, very important. Now there is a definite risk if she goes into labor. So that also we have to tackle. Dr. Chuchi, would you like to add something?
I think we can immediately stop it and we can keep a watch on the INR. And if there's any issue, we can transfuse her with FFP and platelets. But the safety of the mother is always first. Yeah.
So Dr. Jane, I'm going to ask that you continue with some of the challenges, and I'll ask people to raise their hands if they have a question so we can continue, okay?
So when we were talking about not giving antenatal care, there's a lot of things coming up globally that the women, even during COVID era, if she's pregnant, she has all right to be treated exactly like a normal antenatal woman. Now, when you say normal antenatal women, we know that there are several checkups. It's country-wise, specific that you come for 13 or 4, you follow WHO regime, whatever. But then there are certain particular antenatal care limits which one has to come for. There are ultrasonographies which are to be done, the dating sonography, the anomaly scan, and then the growth scan. Why? Because if you miss the anomaly scan, which was the common thing during this period, many a times congenital anomalies were detected very late and they could not be aborted. So there were a lot of issues which were there. There were a lot of pregnancies where, missed abortion continued for a long time. Why? Because the women was not seen by the doctors. So a very clear message where the challenge what we had is that antenatal care has to be given. It is the right of women that nobody should refuse antenatal care. But then we come up with something very new in this era, and that is telemedicine. And this telemedicine has really changed the world because many women have a lot of questions to ask. They have a lot of worries, queries, and that can be taken care by telemedicine. Anything, Dr. Shuchi, you would like to add? Antenatal care?
Yeah, I think one of the recommendation is that suppose she's positive at least for 14 days, if there's no emergency, it's better if she stays in her, and she's mild disease, then she should stay at home and she can delay her next visit for 14 days. And if there's an emergency, of course, she has to be attended to. So COVID should not be excuse for not attending to an antenatal patient.
And it has been seen that even in the medical colleges, the residents have refused just because the moment she got the report of COVID positive, it would be something like this that nobody would like to check her. But then, it shows that we are not prepared, because if we are prepared, we are on with PPE. I don't think there should be an issue of not, examining the antenatal women, which is a mandate. So these are certain things which we would like to add here, that antenatal period, the women has to come, she should be seen. The care what we are giving to all pregnant women should be given to her, but yes, with caution, where healthcare workers have to ensure that they are with full PPE.
And then if you could move on to the other challenges. So the lack of a birth companion, that was done here in the US throughout most of the pandemic until testing was available. I noticed that your patient was on steroids as well. So if you could cover the others, and then I'll address some of the questions in the chat shortly.
There was another challenge which was there, which we realized all over India probably, was that there were no well-prepared triage areas. And in MGIMS, just near the gate, we created a full new infrastructure where we created a triage where one of the nurses who was very senior would sit with PPE, and every patient coming would channelize through her, and then we would divide them into non-COVID, suspected, and COVID positive. So the people who were COVID positive, they were referred to the antenatal clinic in the COVID hospital, which was created in the hospital itself. The people who were COVID suspected because their relatives were COVID positive or there was some kind of history of travel, so they were sent to isolation area, and those where we were very clear that they are COVID negative, they were sent to a different area. Now the problem came when they were asymptomatic women who were COVID positive. So there was a checklist with this particular nurse who would read the checklist and ensure that what maximum we can do and how maximum we can minimize the movement of COVID positive, even if they are asymptomatic, to the areas that was taken care of. All the non-COVID areas also, the healthcare workers were with full PPE, so that even if asymptomatic women comes and they, examine the women, problem should not be there. And the COVID testing, which was one of the major issue, I'm sure you would like to know, Bhakti, you can please add later. So how we managed here the testing was that when a woman would come in labor in emergency, all these women were tested by rapid antigen test. But as we all know that it is not so sensitive, so these women were kept in an area which was isolation area. The distance of the two beds was more than 6 feet. And there, we had sent their RT-PCR as well. So even if they deliver stating that they were RT-PCR negative, but the next day they came out to be positive, they were in a very different set compared to the other one, the one who comes negative. So there was so much of distance that the cross-infection possibility was not there, and we were taking care of it. Suchi, you would like to add something?
Yeah, and within the COVID area also, we had separate areas like for mild disease, moderate disease, and the ICU, HDU were also together. So triaging was very easy. And we had developed a labor room and OT within this COVID hospital. So in the same area that they were there as antenatal patients, they could be immediately shifted to COVID labor room, and then they could be shifted to HDU, ICU, depending on their needs.
And Bhakti, I would like to add one more thing that because, we are very deficient of staff, because that time, patients were too much, and human resource have been a major challenge. When you talk about India, you see, we are seeing in one day, we are seeing 230 to 270 patients in OPD. So you can imagine that there was so much of human resources scarcity. So what we did was that we had created a hybrid labor room and operation theater. So every woman, even if she delivered, she was treated as if she was in operation theater. And after her delivery, everything was clean the way you clean an operation theater. And that was the reason we had literally no COVID deaths in our scenario, only emergency one, and the other one was who came with severe preeclampsia and DIC. These were 2 deaths referred from outside. So these were some challenges, and we did try to look into those challenges, and we did try to cover them up. And 3 areas what needs to be separated. Now, I think every hospital should have that. Please keep a non-COVID area separate, isolation area separate, and COVID, positive areas separate. And you have to divide your staff also in the same way, so that every area is looked after nicely.
Thank you. So I'm going to ask you to stop sharing your screen, because I have a lot of other questions to ask you. But what I'm hearing is that, in times of COVID, the challenge of managing COVID positive pregnant patients is one, continuity of care, and that can be achieved by delaying visits so that they're not acutely infectious when they come to the antenatal visits, using telemedicine to check up on them, using rapid testing, and using PPE until rapid testing is available. The other thing I really heard was your emphasis on triage and the importance of triage.